HCV micro-elimination in Alabama. This activity is sponsored by Prime Education through an independent educational grant from AbbVie. My name is Renata Anderson, and I am the Viral Hepatitis C Prevention and Surveillance Manager with the Alabama Department of Public Health, and I will be today's moderator for the workshop. Our expert speaker for today is Dr. Ricardo Franco. Dr. Franco is an associate professor of medicine in the Division of Infectious Diseases at the University of Alabama at Birmingham and board certified in internal medicine and infectious diseases. His interest focuses on viral hepatitis and hepatitis C elimination efforts. We are so happy to have you all here today. First, I want to go over some housekeeping duties before we get started. Continuing education. So this slide shows how Prime, as the accredited provider, is able to provide 1.5 hours of CE credit for the listed professionals attending this workshop. And this slide shows Prime Education's efforts to resolve any potential conflicts of interest as part of its educational planning process. And this slide shows the faculty's disclosures of relevant financial relationships, and again explains how Prime resolves any potential conflicts of interest as part of its educational planning process to ultimately put forth this workshop. The chat feature. So for today's program, we want this to be very interactive. So if you don't mind, go ahead and tell us where you're tuning in from, what organization you're with. If you want to put your name in the chat, we know we have some folks who are here in Alabama. We also have some folks outside of the state. Just tell us where you're from. You can use the chat box to send your comments or questions. And if you need technical assistance, you can also send us a message. We'll be doing polling questions throughout the presentation, and we'll be reviewing your responses. So you'll find the poll tab to your right. We also have handouts. The slide deck is available for download if you wish to print it out or simply follow along on your computer and take notes. In order to get your credits for today, we will have a program code. And that is how you will claim your credits. Please write down the program code that will be given at the end of today's session. You will be redirected to a page to complete the post survey, and that's where you will claim your credits. We will be planning to record this session today so that it'll be available for anyone who's wishing to view it in the following days. Here are today's learning objectives. Just take a short minute to review the learning objectives so we can see why we are all here today to learn.
All righty. Thank you, Ronada. It's a pleasure to be here. This is very exciting. Ronada and I are partners in crime for quite a few years now. So it's a great pleasure to be here with you. And this nice audience, I see some familiar names on the chat. Very excited that everybody is joining for this hour and a half. And I am very glad to say that I do have outstanding material put together by Prime to share with you. I think you'll find it extremely relevant to your practices, so much so that I tend to keep it to my own practice as a template and reference tool moving forward and improving my own ways to deal with hepatitis C. So in terms of overview, pretty much 1% of the adult population nationwide and very closely in Alabama is infected with hepatitis C, meaning they have viremia by PCR, which is different from seroprevalence, which tends to be higher than that estimate. For the most part, people in Alabama infected with hepatitis C are older than 50 years of age, but this is changing rapidly because of the opioid epidemic, especially in the Appalachian region, which gets our northeast part of the state. And so much so significant increase in incidence of hepatitis C, not only a very large prevalence, as I just mentioned, but the incidence is increasing. And one of the ways, unfortunately, to realize an increase in hepatitis C cases is to see an increase in overdose deaths. So the rates of drug overdose deaths in Alabama in 2019 was as high as 16 per 100,000 population, which is actually lower to many other states in the Appalachian region. And in 2020, opioid overdose deaths actually increased by 20%. So that is a indirect evidence that along with this staggering burden, we also see increases in hepatitis C cases that goes along with emergence of injection drug use. The US has a very comprehensive viral hepatitis national strategy, and in tracking how we're achieving goals of that strategy, we are doing relatively well and on track in preventing viral hepatitis related deaths, both from hepatitis B and C. And also we are trending in the right direction as far as providing vaccinations, hepatitis B vaccinations, and also hepatitis A vaccinations. But we're not on track at all in preventing this rising in incidence. And the major causes of that is severe gaps, profound gaps in harm reduction, especially here in Alabama, and also profound gaps in achieving what is expected to be appropriate syringe exchange volume to protect from hepatitis C transmission among people who inject drugs. WHO sets a bar that countries should make available about 300 syringes per person who inject drugs per year. In the US, traditionally, as a whole, this gap is not only in Alabama, this is nationwide, only attend 10 to 20% of that goal. Then you can imagine with these gaps, how it's very difficult for us at this juncture to prevent or avert the increases in hepatitis C incidence. Ronada, back to you, our first polling question, please.
All right, so here's our first polling question. In your practice or organization, at what steps within the HCV care cascade do you experience the biggest challenges? A, screening, B, linkage to care, C, treatment, monitoring, patient education, and counseling. Do not feel afraid to submit an answer. Do not feel like you are going to give the wrong answer. Go ahead and input your answers. Dr. Franco, I'm interested in finding out what the answers will be.
For me, yeah. So for me is by far linkage to care. I work in a tertiary center, so I receive referrals from patients that oftentimes live far away from UAB. And because of that, I really think that linkage is a major gap. Another thing that contributes to linkage as a barrier is that we diagnose a lot of patients with Hep C out of the emergency room. And oftentimes, as a newly diagnosed and having many competing priorities, it's very hard to link them to care, or it's either that or require a lot of resources that are not always available.
Right. Okay. So we have our results here, and screening is 11%, linkage to care 21%, treatment 21%, monitoring 23%, patient education and counseling 25%. So that's surprising. So we got a tie there with linkage to care and treatment. They kind of go hand in hand. Monitoring, um, and it's interesting that patient education and counseling is actually the highest percentage. And I think that would also depend on uh, all of our participants here today.
Yes, it's an interesting distribution of results, and yeah, we can certainly help with all these barriers, and I think you'll find the activity very productive.
Okay, so this is our discussion question for our participants. How has the COVID-19 pandemic impacted HCV screening and management in your practice or your organization? What strategies have shown success in overcoming potential delays in HCV screening treatment or care associated with COVID-19 pandemic? Now, Dr. Franco, we have all had our setbacks and challenges with COVID-19. And I've heard from a lot of primary care clinics that really had to take a back seat to hepatitis C screening and care. So, what were some of the strategies or even some of the challenges that you've seen with COVID-19 and being able to do screening and care and management?
Yes, when you look at the hepatitis C situation, even before the pandemic and how the pandemic made it worse, it's just tragic to see. And of course, a lot of our partners across the state, they really had to stop temporarily any hepatitis C work or even any harm reduction work. So because patients needed to be quarantined and we had to shape our practices, everything fell behind terribly. One of the things that helped, especially during the pandemic, was to do some telemedicine at any capacity. Either formal telemedicine with the ease of the policies and reimbursement that happened because of the pandemic. So that is certainly something that was very important for us, and I am sure for many partners across the state. But I like to refer to the informal ways of doing telemedicine as well, which is basically picking up the phone and re-engaging with patients and at all rows of the clinic staff, case managers, nurses, and providers. To joining together on an effort to pick that up, and I saw that happening in many instances, and we use this crisis time in our practice to revamp that call back championing to re-engage patients in care, and it's been very nice to see the benefits of their work.
Right, great. And for our participants, don't be shy. Please share your thoughts in the chat box and let us know if you have any questions or if you just want to put some comments in the chat box. I don't see any comments pertaining to this discussion at this time, so we'll move on to the next slide.
So as a buffer slide, we'll be addressing local gaps and the national guidelines, the potential strategies, and improving hepatitis C screening rates moving forward. And what's nice about all this workshop is this, every single one of you taking participation, and this is part of a stepwise approach with a ultimate goal to identify action items or even a plan to improve your clinic workflow processes. We're basically on the fourth step of this endeavor, and we'll talk about a little bit of the three steps that preceded what we're doing today. So we firstly identified and enrolled 3 local healthcare clinics, 3 outstanding partners that have been working with us for a number of years now in 3 different cities. We contacted Medical Advocacy and Outreach and Copeland Care Clinic in Montgomery, Alabama, as well as AIDS Alabama South in Mobile and Cahaba Medical Care in Birmingham. And we had sessions with providers and patients about the ABCs of viral hepatitis, and went over comprehensive topics from transmission, available therapies, all the way to how to think about harm reduction and tips for protecting your liver and staying healthy. We also distributed, again, outstanding material developed by Prime, this HCV care toolkit to be distributed, which is a very encouraging and facilitating maneuver to introduce the matter in very busy clinical settings, and also dealing with patients that have a large number of very intense competing priorities, but just to catch their attention to something that, that is silent but deserves a lot of attention, as you know.
Dr. Franco,
Yes.
would you comment in relation to our discussion question or our discussion? We do have a participant that said Medicaid expanding the coverage for hepatitis C in regards to liver staging of fibrosis, that has been really helpful in getting patients who have been delayed treatment. So that's good to hear.
Yes, yes, I totally agree with that, and that is certainly maybe not as much as a consequence of the COVID pandemic, but certainly a huge facilitator. And we're looking forward to the day that Medicaid will not require sobriety of any, of any duration, or a proof of a negative drug test. That would also be outstanding if we can ever see that one day. But as far as and thank you very much for the comment, and the learning session demographics, back to the stepwise process that this workshop's part of, you can see we had a pretty large number of patients, 313, and also almost 40 providers giving answers. And you can see that actually the demographics of our patients, we had a very young population, mostly male, with a pretty diverse distribution, I would say, with overrepresentation of minorities compared to the general distribution in our state. And the vast majority of them covered by public insurance. So this is really a very interesting demographic that represents what we mostly see in our clinics, for sure. And most of them diagnosed with hepatitis C. And in terms of providers, we had a very experienced audience, which is the intent of this workshop, of this work. But we also love newcomers, and we we really like to ask the providers that have experience, that are already engaged in hepatitis C, to identify the next champion, because as it stands right now, we don't have enough capacity still to attend the demand. But you can see that they had about 12 years of experience, and the number of patients that they see weekly, those are very busy providers, and that see hepatitis C quite often. So we tend to attract with these workshops patients that, providers that usually see hepatitis C all the time. So we also, in clinic settings with high prevalence, and I would say high incidence of hepatitis C, and we have to move forward in engaging more and more of those providers that are in these high yield settings that might not be as engaged. Those will be the highest yield as far as asking for help of these key providers that need a little nudge to be involved in not only testing patients, but also linking them to care, or being themselves the linkage that is missing, and go ahead and treat them. So, and one of the key pieces of the workshop moving forward, and one of the first steps, is to have clarity of where we stand as far as hepatitis C screening. So I believe a lot of you remember back in the day in 2012 when the CDC said that every baby boomer should be screened for hepatitis C. That was a big game changer in terms of screening. And then moving forward 8 years, they expanded that recommendation, which reflects the expansion of opioid epidemic and the increase of hepatitis C incidence again, to screen every adult at least once in a lifetime, and also screen any person with the following risk factors. So we still do a lot of risk-based screening, but the key here is that we moved away from that to an approach where we should be doing this universally for adults. We also should be thinking not only about one-time Hep C testing, but also annual Hep C testing. You know, in key groups, people who inject drugs, HIV positive MSM that might exhibit high risk sexual behavior, and also MSMs taking PrEP. So those need annual Hep C testing, and also some others that actually might need periodic Hep C testing. A classic example is perhaps a former injection drug user that gets treated for hepatitis C and cured, but then years later might have a relapse and will need to be retested because of that. Doesn't really imply that person needs annual testing, but it might need testing for that particular instance of that short-lived relapse in need of use. Ronada, please.
All right. Here's our second polling question. In your practice or organization, do you offer one-time HCV screening for all individuals? Yes, no, or not for sure? All right. Yes, no, or not for sure, Dr. Franco. That you know, you some people might be surprised, but there are actually a lot of practitioners or mid-level managed care or case managers who don't know if their organization offers hepatitis C screening. Some people think, which it should be a part of, like we just talked about, the one-time screening for everyone. But that's not the case for every organization or practice. Okay, so here are the results. 23% for yes, no, 59% for yes, 21% for no, and like I said, 21% for not sure. So no and not for sure is tied there.
Yeah, this is a very interesting question. If you're looking at it, I would say that for any given provider answering the question, that would answer yes, no, or not sure. So the answer could be right. All three answers could be right for the same provider, depending on how you take on the question, because some providers might actually be testing every single patient, but they don't know if their colleague next door is doing it. So if they're speaking for themselves, I can see a lot of answers being yes. But as far as doing it as an organization, it might be a more difficult question, and you might not even be in position to know if they're really doing it. It reflects the complexity of doing universal screening in any given healthcare setting. This is not an easy thing to do. And it's one thing to have the recommendations written in stone and endorsed by the Preventive Task Force and the CDC and everybody else. And another thing is to implement in your practice and be strategic about it and consider the trade-offs. If we're going to be concentrating resources on this, we're going to take resources from something else to do this, or you're going to find the extra resources somewhere else. So it is understandable that we had that distribution of answers. So, and as far as the screening algorithm, so it is a two-step process. You need an antibody test, you need a viral load test. And for the audience we have today, it's pretty clear what an antibody test do and what a confirmatory PCR test do as well. Uh, but when we're engaging new providers or the ones that are used to refer patients but not really manage hepatitis C, they might struggle a little bit with this notion, to the point that they might say that a patient that has been treated and cured for hep C, that comes back with them and they order an antibody test and it's a positive antibody post-cure, they might tell the patient, well, your hepatitis C is actually not cured, which is not accurate. And I see that in my practice, a lot of patients that have been treated and cured already, they find a new primary care physician and they get tested for the antibody again. We know the antibody test is a immunologic fingerprint and will be positive for life, even among those who have been cured already. So whenever you are rescreening someone that have been cured, you can only do the viral load test to really have meaningful information if they're really reinfected, or if their hepatitis C treatment failed, or if they remain, if the hepatitis C remains gone and they're not catching it again. So that two-step process is extremely important for newcomers starting to do this job to understand. And of course, people that are finding out about hepatitis C or being tested for the first time, the Hep C antibody test is really the first test to do. So as far as gaps and barriers in hepatitis C screening, so we did have in our surveys prior to the phase we are right now with our process, what was the biggest challenge in screening? And it seems to be a disclosure, a patient disclosure issue, and also reflect our old mindset in doing risk-based screening, kind of like waiting for the patient to ask to be screened because they know about a risk factor, and the patient has to be willing to disclose. So providers will say, well, the patient might not know he needs to be tested. And that's the old mindset. And with universal screening, we don't really need to rely on patient knowledge anymore. Like you see, 52% of the providers said that patients' lack of knowledge is a barrier for screening. So now the new recommendations are addressing that very problem. If we're doing universal screening, we don't need to rely on a patient knowledge to be asked to be screened, or we don't need to be asking stigmatizing, embarrassing questions about risk factors to even start the screening process to begin with? And the second question, for which patient population do you need focused training tools in order to improve engagement? And a big one, the two biggest ones were people with injection drug use and people with HIV infection, which those are niches, special niches that are not as always present in every single primary care setting that you may find everywhere. There are, and several are actually represented here today in the workshop. I see you, and you are used to see HIV co-infection. You are used to see active injection drug use, but those are niches and expertise that might not be as available to every single primary care, and I can understand those being a barrier. How to empathize. And once you empathize, then you know how to approach a delicate question as far as doing the test, which, by the way, the universal screening facilitates that too.
Dr. Franco,
Yeah.
so Teresa has put a question in the chat, and I think this is really for everyone. You know, we always have the challenge with the cost of RNA tests. And that does seem to vary in my experience from working with different clinics, from clinic to clinic. Um, and this is in reference to persons without insurance. Sometimes I hear from some clinics they actually do better with patients without insurance and using the patient assistance programs. So I think it does vary from one clinic to the other and based off of the experiences that different clinics have um, with that care coordination. And not to get too much into the weeds of it, because we could talk about patient assistance program in a session all to itself. But if you just like to make any comment on that.
Yes, absolutely, Ronada. And it speaks to how savvy our audience actually is. I'll make brief comments and I'll go to the point because I know they will understand. I totally agree. It is easier to get a hepatitis C treatment approved by patient assistance compared to Alabama Medicaid nowadays because of the sobriety restrictions. And what happens is most of these patients that are well engaged, highly functional, that that the provider feel good about the timing that now is a good timing to treat Hep C, they might actually be doing everything right, but still smoking cannabis. That's the most common scenario, and Medicaid will not cover those patients. So you have to resort to assistance instead. And that's not ideal either. And that's a policy gap in our state that has been addressed in other states. In fact, 11 states already don't actually require any prior authorization at all to cover hepatitis C treatment. Okay, 11 states. So we're really hoping that Alabama will follow suit in the near future. I see a question about cheaper HCV RNA tests. Yes, I think that's a big issue. In some of our outreach projects, we have been able to negotiate better pricing, and I think it goes a long way if Teresa, if you want to champion that idea, if your organization is purchasing larger amounts of HCV RNA and want to negotiate a better price, Tony Lee has experience about this, and I think we have we chat about this some weeks ago, maybe. If he hasn't come back to you with an idea for that, you guys should talk about it for sure. And how does marijuana prescription affect Medicaid? As it turns out, if someone has a positive urine drug screen for cannabis, it's considered an illicit drug use, and as you would see as unethical perhaps, patients using illicit drugs in Alabama are denied hepatitis C treatment. If you ask, have lawsuits came out of this? Yes, in other states. Patients sued state Medicaid in years past, saying that it's unethical just because someone, if I'm a patient and I'm using illicit drugs and I need high blood pressure medicines or insulin for diabetes, you as my insurance, you cannot deny that to me because I use an illicit drug. So why you could, deny that for a hepatitis C medicine? So that's the basis of the lawsuits that preceded, other states lifting the sobriety restrictions to begin with. That's how a positive cannabis test affect treatment approval in Alabama. Those restrictions remain in place in our state. And another question, to address policy gaps, what are your recommendations when addressing policymakers, primarily toward introducing harm reduction methods? That certainly is a question for another day, perhaps, but I'll say, suffice to say that, for example, just as an example, our chief medical officer in Jefferson County, Mark Wilson, Dr. Mark Wilson, he's been trying to approve a pilot syringe exchange program in Jefferson County for about 5 years now. And every year, the project doesn't go to vote because of filibuster threats, or because it doesn't make the list of priorities for that calendar year to be debated and voted in the chamber or in the Senate. So yes, that has been a lot of movement trying to improve harm reduction, trying to decrease Medicaid restrictions, but from prior experience, lawsuits driven by patients has been the most effective mechanism, which for some reason hasn't happened in Alabama yet. Just a couple weeks ago, AIDS Alabama, with out-of-state representation, submitted a administrative complaint to the Department of Justice against the sobriety restrictions applied by Alabama Medicaid to hepatitis C medicines. That made the news a couple weeks ago. So another example that, you have ongoing advocacy towards that. Yeah, and cannabis is legal in many states, so did it make sense? Yeah, so there are discrepancies how to approach cannabis use in different states, and certainly we are on the other end of the spectrum, right? Compared to Colorado, for example. Yeah, great questions, great comments. Absolutely. Thanks for participating. All right, so another provider survey, we asked which of the following patient populations does your practice routinely screen or refer for screening, and a lot of, and it was an improvement post-activity, so everyone who wants to be screening. So the real question in the screening in 2022, the real question is, do you want to be screening for Hep C? Which may be followed by a patient question, why should I be screened? And then you're going to say, not because I'm thinking you have any risk factors. You're going to just say, because by recommendations, every adult should be screened. Are you concerned otherwise? Maybe if you could have had an exposure in the past. So that might be a way to introduce the further assessment, but the screening itself, it's already done, right? You don't really need to go into the nitty-gritty of risk factors, not to that level, to offer the test and already clarify why it needs to be done. That's the whole benefit of universal screening in facilitating the discussion that it's oftentimes embarrassing, and you don't want to judge or be judged. And sometimes judgment just comes out very easily and sometimes even out of control. So Ronaldo, back to you.
So, our discussion question: what works for you? In your clinic or organization, what are the main reasons for the existing gaps in hepatitis C screening? And what are some strategies for overcoming patient, healthcare provider, and system level gaps in hepatitis C screening? So, when Dr. Franco, in your experience in working especially with primary care providers, what do you see as some of the main reasons for gaps in hepatitis C screening?
Yes, like I said, it's a very complex endeavor. You have to have involvement from all the way from administration to everybody doing the screening. A good example is the UAB emergency department. They're able to do universal screening in every eligible patient, basically patients that are not too sick or unstable coming to the emergency room, by decentralizing the process and getting the nurse staff involved and making it very easy for them. That required buy-in from all levels, from administration to the lab to the providers, providing counseling to the ones that tested positive, and to the nurses actually implementing the screening, basically asking that very question: do you want to be tested? So that's not an easy process. I think that's the main challenge, is how you create a buy-in to coordinate that endeavor in your organization is the main thing. And honestly, it requires a lot of talent and know-how. And the best person that I can think of that did this years ago is James Galbraith here at UAB. He was the mind behind of doing all that in the emergency department. Now, the emergency department sees like 65,000 patients every year. So that might not be the volume that you're going to be dealing with. So if you're dealing with smaller volumes, the smaller is going to be the endeavor, but you have to have widespread buy-in before you can really go for it.
And so, for our participants, I am wondering what you see as some of your system level gaps. I know we do have some large clinics that are participating, and we have some small clinics that are participating, but everyone has a system level within their organization or their clinic. So we are wondering what are some of those gaps, and potentially how we can work on it for hepatitis C elimination. So please go ahead and input any of your comments. If you happen to think of something, I know sometimes when I'm on sessions and attending webinars, I'll have a thought that comes to my mind 5 minutes later, and that's just fine. Please feel free to input your comments at any point in time that you think of them.
Yeah, one thing that is very helpful is that LabCorp and Quest, they're usually the main contractors. They do reflex testing now, and so which require just one blood draw. But that's at the end of the spectrum of the process that I was talking about. Even before thinking about how reflex testing helps you, what's the level of buy-in? Does everybody in your organization understands why everybody needs to be screened?
Exactly.
And if that's not the case, that's what, that groundwork needs to be done. But I can see that most of our audience, they already went through that process, and they're trying now is to consider the costs of doing it and the cost effectiveness of doing it. And there are studies saying the universal screening is cost effective, but how generalizable those studies are to every single organization thinking about it, those are very relevant questions, and I might not have the answer to every single one of the partners, but they're very good questions for sure, and certainly a challenge.
Okay, let's go on to our next slide.
So for the question, so what makes it difficult for you and patients to get tested? for HCV, and we had patient answers in green and provider answers in blue. And you can see that stigma is really the biggest theme for patients, and that's where we need to work on. And for providers, as 29% said, do not know where to get tested, our assumption that patients don't know where to get tested, and perhaps some of the old mindset that this needs to be risk-based, like as if we will have a facility that is geared towards servicing injection drug use, a treatment center, and perhaps they have a way to test Hep C, but this is now widespread, universal, should be part of every single primary care setting. So yes, again, when you look at the answers, you understand why the recommendation for screening changed quite a bit. Another question was, what would make it easier for you and patients to get tested for hepatitis C? Again, from patients' perspective in green, if I can find a provider that, first of all, is not going to judge me, and second of all, is going to spend time and tell me what's the deal with hepatitis C, that will go a long way. And for providers, it's more of the same. They do recognize there is a gap in supporting patients and not being so judgmental. So what are some tips then to do better screening? So the first one is given. Embrace universal screening for all adults and pregnant women, by the way, and realize that this should be happening in a number of settings, some of them not as conventional, such as correctional facilities, mobile units, homeless shelters, refugee health centers. So that's a given. Another one that we don't think as much about, we did this actually here in Alabama quite a lot a few years past, and involved several of our partners, is to do a rapid Hep C test. That is, so if you think of HIV rapid test, in HIV nowadays, someone at the comfort of their home can pick up a saliva test and know the results at home in 20 minutes, and it costs about $50. That's HIV. Well, Hep C is not quite there yet. Can you test Hep C at home? Yes, you can, but it requires a finger prick. It's not saliva, and you're not going to know the results the same day. You have to send your dry blood to an outside lab that will read the result under CLIA waiver and then tell you if it is positive or not. Can you do a rapid test in the clinic? You can, but again, and know the results in 20 minutes in the clinic? Yes, but it's not at home. So we don't have for Hep C what we have for HIV, where it's one that is at home, saliva that doesn't need blood, and you know for 20 minutes. So you can only have two of those, and it's not going to be saliva or it's not going to be at home for Hep C. So hepatitis A testing is important because you need to immunize injection drug users that might be at risk of acquiring hepatitis A. Hepatitis A is a fecal oral transmission disease. However, in injection drug use, in poor sanitation conditions that they might be injecting in poor sanitation conditions, you can have the fecal oral transmission, especially among homeless patients or patients in correctional facilities. So tagging along hepatitis A testing and immunizing the ones that are antibody negative is important. Of course, partnerships with community outreach, professional societies, and academic institutions goes a long way. I guess that's what I'm trying to do here today, and leverage the preventive services to expand Hep C testing and address cost and insurance barriers. Um, that's part of the negotiating pricing, I guess, that would be important, especially if you're doing high volume testing. Of course, provide materials in different languages, especially if you see a large population of Hispanic patients. And if you can, and if it is important to your practice, to integrate this to hepatitis B and HIV testing. And that's what we do here at 1917 Clinic. If you're doing PrEP, some of our partners do, very important to do that as well. Where patients can get tested for hepatitis C, you might recognize your clinic you might recognize your clinic there. I would add as well clinics by the Jefferson County Health Department, and they might actually be able to provide hepatitis C testing even if the patient is not engaged in primary care at the moment, especially at the STI clinic. All right, so switching gears, we'll be talking about gaps in linkage, kind of done with gaps in screening. So everybody with Hep C should be linked to a provider that can prescribe medicines, do the assessment, and prescribe, which involve a number of those steps. Sometimes not all steps, but perhaps most of the steps are applicable to most patients diagnosed with Hep C. But the main thing here is, this might be too complicated, it's busy. The main thing is, you're doing a lot of Hep C testing. At some point, someone's going to test positive. So what do you tell them? Especially if you're, early or new to this and doing it for the first time. The way I do it is this: I say, Mr. John Smith, we got bad news. Your hepatitis C test came back positive, but there is a lot we can do about it. This is a curable disease. We have medicines that can cure the vast majority of patients. So that the positive cure nature of it should be said up front. Then in delivering bad news, you want to know how much the person getting the bad news already know about the problem. What do you know about this? He might say nothing. Then you go from the basics. He might know a lot about it, and actually might have more questions down the line. But regardless how much the person know about it, because it's curative, I guarantee you at the end of the conversation with you, they'll come out of the conversation with a better outlook, even if they're receiving the bad news. And if you're getting a referral, you might actually want to make sure that the patient understands that they're seeing you for hepatitis C, so you're not breaking the news, like saying, hello, Mr. Smith, you're here for hepatitis C. So you might want to ask first, what brings you here today? Because sometimes the communication loops might not be closed always. And they might say, I'm not sure why I'm here. And then you might say, well, another doctor, or when you were in urgent care, somebody tested you for hepatitis C. Did they tell you that? Oh, yeah, I got tested, but I don't think I got the results of the test. So some of the things that I learned the hard way doing this for a while now. All right, polling question, Ronaldo, please.
All right, so here is our third polling question. In your experience, which of the following barriers most impedes linkage to care after hepatitis C diagnosis? Select your top one. All right. So lack of hepatitis C awareness, about hepatitis and liver health, lack of an established protocol for referrals. That's a big one. Limited or lack of access to local hepatitis healthcare providers, lack of case management, limited healthcare provider networking and mentorship. We do hear that a lot. That's challenging. Lack of time and priority. I don't know how you guys are going to pick the top one. Those are all challenges for everyone with hepatitis C diagnosis. Um, where would you put your top one in your experience with working with primary care providers, Dr. Franco?
My answer was the lack of case management. I feel like as much resources we put on screening and how much resources has put on treatment, we have this hole where there's very little resources in navigating patients. Uh, this is something that cancer care has learned how important it is. There has been so much work and resources put in on navigating cancer patients from diagnosis to treatment because we know if they don't link, it's deadly. Uh, because hepatitis C can lead to liver cancer, I think we have to think about the same process, just give the same priority to hepatitis C, even though we know most of our patients will have a very low risk of that. But if we just leave them out there, not linked, they'll have a third of them will have bad consequences, either from liver failure or HCC. So that's why that was my answer. But all the other answers are also reasonable because we really need resources at every single step.
Right. Okay, so we have the results here. So 3% for lack of healthcare provider awareness, 28% for lack of an established protocol for referrals, 17% for limited or lack of access to healthcare providers, 34%, there you go, that's our highest one, for lack of case management, 7% for limited networking and mentorship opportunities, and 10% for lack of time or low priority. All right, so now, and when it comes to case management, I mean, it's kind of interesting that you bring up cancer organizations and care coordination for cancer. And then we also talk about the similarities of hepatitis C and HIV. And for years, I think that hepatitis C has kind of been stuck in the middle there because we don't get the funding for, or the funding like HIV, since hepatitis C is curable, but at the same time, like you say, it can lead to cancer, but we don't have those private, large resources and donors that support cancer care and treatment for hepatitis C. So those are some things that I think us as stakeholders and providers and advocates can look to work on to push that forward.
Yeah, yeah. It's the story of our lives, isn't it? And I agree. So the lack of established protocol for referrals is a very important one, and has been a big effort from AASLD, that's the Liver Society, and NIDSA, that's the Infectious Diseases Society, to put out there a HCV guidance. Just for everybody that haven't seen this, you can Google hcvguidance.org. I put it on the chat, and that is a invaluable document. The thing is, it does exist, but if your organization doesn't know about it, then you're not going to have a protocol for you. So that walks through any champion that is interested in establishing a protocol for your practice. That's a guidance, that's a template that you can follow suit and take things that work for you as you see fit. And in our wrap-up slide, I'll give you maybe 5 reminders whenever you need to refer patients and whenever you can manage them in your own practice if you're doing primary care. So we'll get back to that. Now, another question that we had in earlier phases of this workshop is, for your patients who have been diagnosed with Hep C, what is the greatest healthcare provider level or clinical level barrier preventing linkage to a specialist for evaluation? So limited access. And that's an old problem. We just don't have enough hepatologists, and we don't have enough infectious diseases doctors that available. And let me say this: at least for infectious diseases, I'm an infectious diseases doctor. I can confidently tell you that only 10% of my infectious diseases colleagues actually treat hepatitis C. 10%. I'm not sure about gastroenterologists and hepatologists, but I believe it's maybe a third of them that do this. So it's not only that the specialty is scarce, we don't have everybody in that specialty dealing with it. So if you're still in doubt that we need primary care involved to treat Hep C, that's another statement. Because the specialty itself, they're busier with other things too. So, or they might be not as interested in hepatitis C as they should too. So something for them to reassess. So what are the tips to improve linkage? You need a strong outreach. You need community teams. You need to facilitate appointments and reschedule and make it as easy as possible for the patient. Even if you have general policies for appointment, you might want to make an exception for hepatitis C patients because yes, they're kind of special. And that has been some reason for advocacy I have to make here in the UAB system to allow them to be scheduled more, a greater number of times until they can finally make it to the clinic. Set up referrals and additional services. You got a partner if you don't have this available in-house, but you need to have a go-to person in psychology, social care, or even immigration services to help you getting this patient, ready to eventually be treated for Hep C if there's too much chaos from other things going on in their lives. Leverage mobile units whenever available. Work closely with Ronada. Ronada does have surveillance and prevention grants that she can work with you on that and even provide resources and make it as easy as possible for you in partner with that's a possibility. And you need a champion in administration. I cannot emphasize this enough. A champion in administration, a champion among providers, a champion among nurses, and a champion in your case management. So if you have a champion in all those, a group of champions there, it goes a long way. I'm speaking the truth here. And we do have resources where to find providers. Many of you are Hep C treaters, but many patients ask, and we have our coalition. You actually part of that coalition that test and cure hepatitis C here in Alabama. But there are other nationwide tools to find a provider anywhere in the country. If you need, or if somebody asks you where to find them, maybe a patient that moved and it's looking for a new doctor. Those are links with good information. How about gaps in treatment now? Ronada, polling question.
All right, polling question 4. What is the main barrier to hepatitis C treatment in your practice or organization? lack of hepatitis C prescribers in your area, lack of established referral protocols, cost of insurance coverage, prioritization of other conditions, socioeconomic challenges, stigma, confidentiality concerns. All right, so we should be pretty good at this by now with this polling. Um, main barrier to treatment. What do you think, uh, Dr. Franco?
Yeah.
And I think it also, again, depends on the really a lot of things, the organization, the area you're in. Um,
Yeah,
so
I can see the answers picking up, and it's coming out cost insurance, and prioritization of other conditions and socioeconomic challenges. Those are all very valid ways of thinking through this. If you ask my answer was stigma. And the reason I put stigma is because just from the perspective that stigma might be underlying the other two major ones, cost and insurance coverage and socioeconomic challenges in a way, and also driving the lack of access to harm reduction. That's how I thought about this. I think we still underestimate the amount of stigma we live in, and the amount of segregation that we live in, how everything is structured around us. It's in silos. How much we really embrace injection drug use and what everything that injection drug use represents, right? Are we bringing these issues, truly bringing these issues to our table, so to speak? And we're equality fit into all this. So I think thinking it that way, that's why I answer stigma, uh, reflecting on
okay.
the other issues too.
Well, we have the results, and so we have 11% that say lack of prescribers, 4% lack of established referral protocols, 39% looks like our highest number. The
Yeah.
cost of insurance coverage, or I guess really that's probably more so lack of insurance coverage. I'm thinking 11% for prioritization of other conditions, and then coming in second is socioeconomic challenges. Um, Surprisingly, Dr. Franco, 7% is stigma, and 0% for confidentiality concerns. I will say this, though, if we probably sent that polling question to patients, we might get a different answer. Um, so there we have it.
Yeah. Very, very interesting question for sure. But as far as assessing fibrosis, this is the traditional classic Medovere scale, and you got to always think about this when you're checking patients and screening for Hep C and treating Hep C. It's very, very, very important. Um, and there are a number of ways to do this assessment that really doesn't require what this slide is showing you, which is biopsy slides with the fibrosis stain and showing how that progresses in terms of amounts and bridging, and then entrapping hepatocytes and not allowing proper blood flow through them, which is the stage 4 severe fibrosis. It's important to realize that the earlier you treat patients in this spectrum, the greater is the mortality benefit, even among patients that don't have cirrhosis yet. And this slide don't get fooled. This slide doesn't include end stage liver disease. This slide only includes patients that have normal liver function. They can go from stage 1 fibrosis to 4. Once they go to 4, years later, they might get into liver failure, and then we have tiers of liver failure as well, like 3 or 4 of them. But just treating patients early in the disease course, way before they get into liver failure, is important. It has a mortality benefit. And I should say, not only among liver-related causes of death, but actually in all-cause mortality, there is a benefit of treating early. And how we assess fibrosis, there are many ways. You can see in this slide, there you can do MRIs, you can do CAT scans, ultrasounds, you can do biomarkers. But a very easy way to screen for compensated cirrhosis, meaning normal liver function but already having cirrhosis, is to look at the platelet count. If someone is older than 50, 55, platelet count is lower than 160, 150,000, that's compensated cirrhosis. You can also do the calculators. It's available online. It's a very easy tool. You just plug in the patient numbers and they'll give you the results automatically. And give you the breakdowns, how to interpret the results and see what METAVIR score they would have if you were to do a liver biopsy based on the serum markers you put it in there. I know a lot of you already have done this before and many times. And the benefits, like I said, if you're treating Hep C, you're actually decreasing the risk of all-cause deaths from cancer in general, cardiovascular disease in general, maybe dementia, and certainly deaths from liver cancer and cirrhosis. So the way the studies show this, the survival curve, is you have a curve comparing the general population without Hep C and the Hep C infected. When the group that is treated early on, their survival curve is reset and looks like the curve of the people that don't have hepatitis C, the general population curve. You're like resetting the mortality to a lower risk as if they never got infected in their lives. That's what giving them medicine and achieving sustained virologic response mean to them. So it's extremely important. The case study, it's a 33-year-old male diagnosed with Hep C genotype 1 and compensated cirrhosis. He tested negative for hepatitis B and HIV. He had no previous treatment, has a history of injecting heroin. He's on methadone since 2016 with 2 relapses within 5 years, no medical conditions, no surgery history, currently unemployed and living with friends and on Medicaid. What are the treatment options? Can I get treated for Hep C while on methadone? That's what he's asking us. And so the slide has a discrepancy. If he has compensated cirrhosis, he would be F4 fibrosis. So just think of it that way, which is uncommon. He would be more likely for him to be F1 fibrosis rather than compensated cirrhosis. He's a very young patient, but maybe there was some drinking going on back in the day, and we'll just assume he already had compensated cirrhosis. So which of the following treatments do you recommend? Let's just assume he's got compensated cirrhosis. Go ahead, Ronada.
Okay. This is polling question number 5. Which of the following treatments would you recommend for Caleb at this time? Sofosbuvir, SOF, I'm just going to go ahead and abbreviate SOF-VEL, SOF-VEL, and ribavirin, GLE, PIB. I would not recommend treatment for this patient at this time. And while we're waiting on that poll result. We did have a comment, Dr. Franco, regarding since we are talking about a patient, this case study who patients on methadone. We had a comment about patients who are substance use patients who complain about having to have multiple doctor's appointments, and that is a real problem. When you have to go to, let's say, for instance, Caleb, his methadone treatments, and as well, he has a job that he has to work, or works at night, or what have you, these real life issues, and yet he has to try to get to the doctor for this treatment as well. And with CDC, that was one of the reasons that they moved towards trying to do what we call the one-stop shop. We need these patients to get their treatment in the same place that they get their primary care, or the same place that they get their substance treatment. So we need more primary care providers and substance use providers on board to get in the game, so to speak. Do you want to make a comment on that?
Yes. Remember when I told you that among infectious diseases doctors, maybe 10% of them treat Hep C? It's about the same problem in among addiction providers. So this patient might go to the methadone clinic every week, if not every day, to get his prescriptions. So if there was a way to dispense his hepatitis C medicine there, it would be very easy, wouldn't it?
That's right.
And this practice is starting to pick up, and there has been some studies showing how the linkage to treatment is like fivefold greater than referring them out.
Okay.
For the
And we
reasons you
have
mentioned, that they're already busy showing up to the methadone clinic.
right. That's right.
I mean, that in itself is it's a full-time job. So
So, yeah, this is something we need to continue the discussion on here in Alabama. We do have the results in. So Phosphivir, 4%, SOFBL 30%, SOFBL ribavirin 17%, GLE 35%, and 13% said they would not recommend treatment for this patient at this time.
got it. Okay. So my answer was B. So let's go back and see what we're doing. So he's compensated cirrhosis. So um, let's just assume that his platelet count is borderline. I would rather not do glecaprevir bemnifosbuvir because of the protease inhibitor in cirrhosis. You can have some safety signals there because protease inhibitors have exclusive hepatic metabolism. So in cirrhosis, you want to be more careful. I would prefer soft velpatasvir, rather than glecaprevir bemnifosbuvir for that reason. I would not go for soft Velvox. That's a salvage treatment. I would refrain from using ribavirin. That is also more applicable to decompensated cirrhosis, which we should not be dealing with in primary care. And as far as not recommending treatment at this time, that's an interesting one. So let's see what the question stem said. He's on methadone treatment since 2016 and 2 relapses in the past 5 years. If his let's say, degree of life chaos is minimized at this time, he is engaged and willing and motivated, and everything else is in place. From the general aspect of it, he is, everything at home is fine, food security is there, he's looking forward to something, to projects, he might even be involved in having a job. And if those things are in place, more so the drug use per se, it would be fine to treat him. Addiction as a chronic disease can show up from time to time. People can relapse. Dr. Leach is here, so she can tell you it's a chronic illness like hypertension, like asthma, like diabetes. You're gonna have some downtrends of DKAs, of hypertensive emergencies from time to time. So you just have to manage those things. And if you're picking the patient on a good time when those things are controlled, it is a good window of opportunity to go ahead and treat. And the methadone doesn't interact with any of the options listed, I should say.
And Dr. Franco, we're coming up a little our time. We're getting close to our time, so just want to let the participants know that we'll hold off on questions until the end.
That sounds good. That sounds good. So as you can see the slide, so for a treatment naive person without cirrhosis, so that means, let's just imagine he was fibrosis stage 1. So you have two main options. They're both pangenotypic, Epclusa and Mavorette. And like I said, if you were to be cirrhotic, I would slightly prefer Epclusa because of the safety signal on Mavorette side. And you can see there is a big X on the decompensated cirrhosis for Mavorette. So that was the reason I made that comment. Mavorette is 3 tablets taken at the same time once a day. Most of the time, you're doing it for 2 months. So it's greater pill burden for shorter duration for Mavorette. Epclusa 1 pill once a day for 3 months. They're highly efficacious, and they're both really well tolerated. And like I said, I put the same link. So the AASLD-IDSA guidelines is the go-to document to look into that in more detail. As far as Hep C screening, treatment, and monitoring of women of childbearing age and pregnant women and children. So I'll briefly state this, and if this is part of your practice, you're a family practitioner, a lot of the developments that are happening for the adult population is translating into prenatal care. So if the estimated Hep C prevalence in your practice is greater than 0.1% of Hep C in pregnant women, you should be doing universal screening in every single prenatal care patient that you see for prenatal care. And for children, they are born from hepatitis C infected mothers. There is a well-established way to test them with PCRs, because you don't want to do antibody tests because they acquire antibodies from their mothers and they might be positive from acquiring that, but not really being infected. So you really want to do the PCR test instead. And you can treat kids as early as 3 years of age. So that is, so it's translated, all these advancements translating to those scenarios. And you want to do a pregnancy test in women of childbearing age, because as we speak right now, hepatitis C medicines are not still FDA cleared to be used in pregnancy, although there are some studies on the way that might be applicable to select pregnant, patients to be doing it during pregnancy. But for now, you should be excluding pregnancy. And if they are pregnant, to defer to after pregnancy and have a strong linkage process in place to help new mothers that find out that they have Hep C during pregnancy. Question that we had to, as a pre-activity, what makes it difficult for you patients to start or stick to taking medicines as prescribed? So for patients not sure where to refill medication, that is sometimes an issue. Thankfully, not so much to our partners. They tend to use their own pharmacies to refill medicines. And also, but because of that, they might be concerned, they might be judged when they're picking up medicine. So having a supportive environment is extremely important. And for providers, they're concerned that they might not have the insurance, or if they lose the insurance during treatment, then they might not be able to refill. That's a potential problem as well. So the most important thing is to have someone tracking them while they're taking medicine, and if they're picking up the refills on time. And if that doesn't happen, just check with them. If something happened to the insurance, you can tap into the assistance programs to refill the rest of the treatment if they no longer have insurance. So if they got covered for 1 month, they lose their Medicaid, then you can tap into assistance for the following 2 months. No problem. Would you make it easier for you and your patients have been diagnosed with Hep C to start treatment or take it as prescribed? Again, a champion to navigate them. They might feel fatigue and nausea the first 3 days of treatment, and they don't know what to do. So they would have someone to call and say, I'm having this. And then the provider will say, make sure he hydrates or she hydrates, takes 30 ounces of water a day. That might be what's enough, so they don't have the side effects, and to reassure them that the side effects, they're usually mild and they're short-lived for these new medicines. They're not as toxic as the old treatments used to be, interferon and ribavirin. So in terms of tips for your practice and closing gaps in treatment, a lot of hand-holding. That's the main message. It's the counseling, the education, the psychological support. Don't throw somebody off that they're not ready because of injection drug use or illicit drug use per se. See what the overall environment around them, what else they're doing, what kind of control they have of their lives to determine treatment readiness instead. So EHR reminders and callbacks to have these patients back and be treated after they test positive is important. And tell them that hepatitis C treatment nowadays is a walk in the park compared to what it used to be years ago. Simplify the workup, make it easy, minimize the number of visits. I take pride to tell them, you don't need to see me again. You only need to see me once. And if you're ready, the medicine will be sent to you, or you come to the clinic to pick it up. You don't really need to come back here to prove me a point to get your medicine if you can do that from the very first time. Can hepatitis C be used in people who inject drugs? Absolutely. Back to the point I just made, the use of drugs, even active injection drug use per se, it's not a reason to deny unless there is too much chaos going on that you feel like that giving them the medicine at that time, they're not going to be in position to be consistent taking it. That will be the reason not to do it at the time. But if they are accountable from that standpoint, from engagement in care, you should be able to do it. And several studies have shown that in patients with active drug use, in patients on opioid agonist therapy, or former injection drug users. And as far as reinfection goes, the risk of reinfection, if you're treating a population that actively use drugs or exhibit MSM high-risk behavior, is about 5 reinfections by 100 person years. So following 100 of those for 1 year, you might see 5 reinfection episodes. And that's, number one, it's not the majority of them that is actually getting infected. And whenever you see a reinfection, it's a good signal that you're actually treating the ones that are about to transmit the virus. So you're really touching on the high-risk population and making an impact in preventing others from getting infected. So if you do see reinfection, it's actually a sign that you're doing the right thing, and it's not a clinical failure, like I used to think that way. And the way you approach reinfection is listed there. Suffice to say that rechecking the genotype and see if it's the same genotype helps differentiate if this is a reinfection versus a treatment failure. If it is the same genotype, it might be a treatment failure. If it is different genotype, should be reinfection. And also the timelines that the tests were done, that would also help to distinguish reinfection from treatment failure. Again, injection drug use and overdose deaths led to a decrease in the overall life expectancy in the United States, something that hasn't happened in the last 50 years. And that happened when we had 70,000 deaths in 2017. Now we're over 100,000 deaths per year, mostly because of the fentanyl expansion and every single, narcotic, cocaine, meth. It seems like everything now is laced with fentanyl. So it's I cannot emphasize enough how bad this is. And every time you see increase in overdose deaths, know that the new cases of hepatitis C are increasing too, and we have this urgent need for integrated care services tackling both issues. As far as treatment monitoring, I will skip some of this, and I'll say that you have to prioritize resources. Number one, to always think about using the patient assistance programs, and I know you guys do this already. And the assistance programs, they're highly inclusive, and they'll accept anyone you want to treat that you think it's a good time to treat, as long as they're not in inpatient psychiatric care. That will be the only exception that I tried once before and they denied me. Monitoring is easy. There is a lot of formal recommendations in the guidelines, but all you need is phone calls. Are you taking your medicine? Are you having any side effects? No? Okay. I likely don't need to see you. Few exceptions are listed there, especially if they're taking Coumadin, and you might want to recheck the INR. And you also have to always test for hepatitis B and making sure you're treating hepatitis B first if they are surface antigen positive. As far as predictors of loss to follow-up, they're usually young, male, and they have active drug use. Those are the predictors. So that's why I say, but don't get fooled. Don't think that injection drug use per se is the reason they're losing follow-up. It's not. It's because some life chaos ensued and led them to that. And it's not necessarily the drug use. It could be related to that, but it's not automatically due to that. So have those in mind. And you can see it actually for the former injection drug users and the ones on opioid agonist therapy, the rates of follow-up are very similar to patients that don't have the history. It's important for the ones that are F3 fibrosis or greater to be screened for hepatocellular carcinoma, and the ones with platelet count less than 150,000 to be linked to a gastroenterologist to undergo an endoscopy for varices screening. That's the most important thing. And after you cure the majority of patients that don't fall into those two categories, to measure their adherence and just enhance the primary care. You are a primary care, skilled primary care that just cured their Hep C. They're going to be thankful to you for the rest of their lives, and they're going to stick with you big time. So you're going to have to take care of all the other issues across, the lifetime. What makes it difficult for you patients having been diagnosed with Hep C? Following up with a healthcare provider at least once a year. It's basically vulnerability and hardship. That's what there is kind of a consensus among providers and patients, with one difference is that patients are still afraid of judgment even after their Hep C is cured. So you have to continue that ongoing support, because maybe if they have addiction, like I said, addiction as a chronic illness, you're going to need to be supportive chronically through the course of, their longitudinal follow-up. Well, 5 minutes over 2:30. I apologize. We're almost done with the slides. If you can stick around with us, great. I think we spent a lot of time interacting, so that was great. That took time off the clock. So if you can stay with us, please continue. We should be done in about 10 minutes, the most. Another question we had was what would make it easier for you patients who have been diagnosed with Hep C to follow up with a healthcare provider? So what is the facilitator? And again, it's a supportive environment for patients. And for providers' perspective, it's easy of transportation. So just remember when the patient says, I don't have transportation to see you, he might actually want to be nice to you and say, I didn't really feel like I felt, a whole lot of support when I was there, so I prefer not to go. And they don't want to tell you that, right? That might be an implied message. This is always a work in progress. There is always a need to be more supportive. So the sky is the limit here, I'm afraid to say. So tips to improve surveillance, communication at all levels at your organization, adherence to monitoring visits, and emphasize to patients how important that is to have that Hep Secure Lab visits, SVR visit. And also just embedded in your practice, this hepatitis C language. Use your Twitter, your Facebook, your organization website, and talk about viral hepatitis a little more, just like we do for other, more widespread topics in primary care, and embedded in there, or even as much as we talk about HIV in primary care. And as far as patient education and counseling, that's extremely important. And I'll give you an example, just that maybe summarize what you can see in the slide. They're very concerned, first of all, that they're spreading hepatitis C to the household. And it goes a long way to tell them that as long as they don't share toothbrushes and razor blades and nail clips, they can sit after people, they can hug people, they can kiss people. No problem. That's a source of huge relief for them while they're waiting to be treated. And if they're not ready to be treated and you have to tell them no this time, make sure you explicit in telling them that listen, I know you want to be treated. I'm not giving you the medicine today. I'm not penalizing you for having Hep C, or because you had some contact with some illicit substance. It's not to penalize you. At this moment, for reasons A, B, and C, if I give you the medicine now, I've been a bad provider to you. And I feel like it's my job to save you from bad practice. So you take the onus of the responsibility to you rather than being them being denied. And then you say, once those things, A, B, and C, are in better shape, and I know this is going to be in better shape. It can be high blood pressure, it can be lack of housing, it can be, food security, it can be too much chaos. It might be too much chaos in illicit drug use pattern that is self-destructive. It could be that too. But all those things tend to be self-limited if they have the resources and support. They might need to be linked to psychiatry. They might need a ASAM assessment first. Once those things then come back, I'll be right here. You know where to find me. And we're going to treat your Hep C. That is kind of my understanding of being supportive. And that's what this slide is talking about. When we interviewed patients, this sample of 137, 129 patients, they seem to be extremely knowledgeable about the dangers of hepatitis C. And this is great, but don't be fooled. They just need as much support as a lot of other patients that I see in clinic that tell me I know nothing about it. They need as much support. And the reason they know a whole lot about hepatitis C It's because they have been stigmatized. So they bring a lot of baggage with them that is our duty to undo and change ourselves, and they'll need our care for the longest time if we're doing primary care. Ronaldo, back to you.
Okay, so we're debunking hepatitis C myths and misconceptions. What are some effective strategies for increasing patient awareness and debunking common myths and misconceptions about hepatitis C? Um, and I think we can mention one if you want, Dr. Franco, and anyone who wants to put something in the chat can do so as well. We don't have anything in the chat. Dr. Franco, do you want to talk about, or just a short strategy?
The main misconception is that I think is the most important one is that a lot of patients without insurance, they don't believe they can get access to expensive medicines. And it's a breath of fresh air when we say that we have assistance programs, and it's actually easier to get the medicines than if they had Medicaid. So that's my preferred myth to debunk when we see them in clinic.
Yeah, I would agree.
So cultural competency is key to reduce stigma, and I cannot agree more. It's empathy. This is one of the best ways to address stigma is try to exercise as empathy as possible and try our best to put ourselves in their shoes. And like I said, never let a visit end if it's not resulting in Hep C treatment, for them to think that they're not getting the medicine because it's them. You have to say this is a medical decision. It's a technical decision, and it's going to be applicable to you once it's safe to do so. And if you do it that way, I am sure you're going to be treating quickly, maybe 80-90% of your patients, maybe even in the first visit. Because by the time they go through all the hoops to face their own stigma and show up in clinic and have their lives in order enough to spend half a day with you in the clinic and being tested and diagnosed and talked about it, most of them should be already in leeway to and very close to be ready to be treated just by doing that. And words matter. So we gotta avoid some of the words out there and use some other terms they're more sensitive. Absolutely. So empathy is key. Those are the tips. Recognize the patient's identity, cultural values. Uh, Try to learn what is his specific goals and values, what's important to them. I like to ask them where they're from. I mean, they're really from here. You have kids. What's your job? What do you do? Tell them how important it is to treat Hep C. Some patients might have a lot of mistrust. You prescribe the medicine and they don't take it. They leave the office, they go home, they get the medicine by mail, or they come to clinic, they get the bottle, and the bottle sits in the shelf because they had second thoughts. I really don't believe I should be taking this medicine. So you have to spend more time and explain the all-cause mortality benefit kind of talk, right? And evaluate self-efficacy. It's not the illicit drug use per se, it's the self-efficacy that determines treatment readiness. So the wrap up, 5 instances that you should refer out. Otherwise, you should treat Hep C. So number 1, if they failed a direct-acting antiviral already, and they were looking for retreatment. Second, if they have HIV co-infection. Third, if they have hepatitis B co-infection, they have a positive surface antigen. Fourth one, if they have end-stage renal disease, because some questions about kidney transplant might be at play for patients with end-stage renal disease before treating Hep C. And the last one is if they have decompensated cirrhosis, because liver transplantation is at play, and they also need, some other hepatology, general care, varices screening, prevention of hepatic encephalopathy, all those things. So those are the 5 ones: end-stage liver disease, end-stage renal disease, failed DAA before, Hep B co-infection, HIV co-infection. Otherwise, you should be treating them. Back to you, Ronaldo.
All
Thank you very
right.
much, everybody, for your time. I'm sorry we went over 15 minutes.
But great participation, and glad to have everyone on, and take time out of your busy day to join us. We do have one last question. I don't want to miss anyone. Someone wants to know, one of our participants wants to know your thoughts on treating patients engaging in moderate to heavy alcohol use. And I guess that, we would have to kind of determine, we know what heavy alcohol use is, but I guess we will have to determine moderate as well.
Yes. So a lot of patients don't know what moderate drinking really mean, or a moderate use of alcohol really mean. And it's actually a small amount. So one drink per day for women, and up to 2 drinks per day for men, and anything more than that, consistently, it's already heavy drinking. Requiring drinking abstinence to qualify for treatment is a dramatic measure, and I usually do not recommend that, because that's a very strong counseling, and we should not take that lightly to tell someone to abstain from alcohol completely to treat Hep C. But I do like to recommend abstinence from drinking in 2 situations. One is if they have cirrhosis, because in cirrhosis, there's no safe amount of alcohol that is safe for you if you have cirrhosis. So that's abstinence. That's formally recommended, even as heavy of a counseling that is. The second one is if you have an alcohol addiction and you cannot control your patterns of intake. So that's another reason that abstinence is really highly recommended, and in every effort and resources to achieve that. Other than that, requested that every single patient abstain from drinking before you treat Hep C, you might actually go to the penalizing kind of sort of approach, and you want to avoid that. But it's very important to encourage them to at least cut down on drinking, because you need good hydration to tolerate the medicines. And if you're drinking frequently, you might actually get a lot of the side effects, and you want to avoid as much as possible a treatment interruption. So that's in general strokes how we should approach it.
Okay. And so, just to conclude our program, to receive your credit, go ahead and copy down this information, the program code, and go to that website to get your CMEs and CMUs. We want to thank everyone for joining us today. This concludes our virtual workshop, and you have a great week. Goodbye.
Bye-bye. Take care. Thanks, Ronaldo.
Thank you.